Hi, my name is Stott and I'm a hip and pelvic surgeon from Brighton. Today we're going to talk about aseptic loosening, periprosthetic osteolysis, mechanisms and classification. We're going to look at causes of bone loss around joint replacements, wear particle and the biology of osteolysis. This is quite heavy going basic science and we'll try and make it more interesting with having x-rays like this one with you. We're going to look at some patterns of bone loss, mechanisms of failure, and then some examples. Normally this is a question and answer talk as we go through, but obviously with this recording it's not possible. So common causes of bone loss after hip replacement. Aging. As we get older, our femurs change shape and we go from that nice champagne door A-type femur to a stovepipe. And how the hip replacement may have been put in when you were 55 and had a champagne bottle, nice narrow medullary canal. Then when you get to 85, your femur's got wider and you've grown away from your hip replacement. We've got stress shielding or adaptive bone remodeling from Wolff's law. Mechanical factors. When hips start getting loose, they abrade and they can act like files. They're rough. Cement can be rough. Fatigue can cause problems. Fluid pressure. We know that fluid causes bone loss and cysts, and the same thing happens around hip replacements. Particulate debris, however, is the big one. Also, we've got infection and tumours, but we're not going to talk about those today. So a hip. This is wear stimulators in the laboratory trying to put a hip through what it goes through in a year. It all looks fairly easy, but we do on average 1 million cycles per year just walking about normally. But if you think about Andy Murray playing tennis on his new hip, the forces on a hip replacement can be extreme. I've had people ski, snowboard, play football. I've got an amateur boxer and a wrestler who've all had hip replacements, and the forces that are put through them cause wear. And all joint replacements make wear particles. This is a scanning electron microscope of a piece of plastic out of a hip. And how much wear depends on the bearing material, size and orientation of the components, as well as what the patient puts the hip through. So this is how far the hip replacement creeps, or the longitudinal wear in the hip. And you can see metal on polyethylene up to 0.2 millimeters per year. And you put ceramic head on that where it's smaller and it's less than 1.1 millimeter. If you put metal on cross-link poly, you bring the wear rate down, and ceramic on cross-link poly massively down. And then these are trying to make it even lower, metal on metal and ceramic on ceramic. But the human versus the wear particle. The body recognizes these wear particles like small foreign bodies. It's used to dealing with bacteria or small foreign bodies. This triggers a cascade which has been evolved to deal with harmful bacteria. And most of these particles are insoluble and dead, and the body can't remove them in the same manner. So in a simplified bacterial pathway, your macrophage grabs the bacteria and it will attempt to phagocytose the small foreign bodies, then dissolve them in lysosomes. But most wear debris is neither alive or soluble. And after this, the macrophage will activate an inflammatory cascade. So the response is particle and host dependent. Not all particles are created equal. Different particles have different effect, and this depends on the particle size, particle material and concentration, as well as the host and host factors. Just to remind you, how big is the joint cavity? Is it just this area here? Is it just inside the joint? But we could talk about the effective joint space, and that's all around where fluid can get to, because it's the fluid that brings these wear particles. So the effective joint space is anywhere that fluid can get to, and that's all the way around a cemented hip, and in some cementless hips too. Now initially, when you put an implant in, you get a fibrous membrane developing between the implant and the bone called the pseudosynovial membrane. And that contains a lot of cells, but it also contains particles of different sizes, such as plastic, titanium, cement, and cobalt chrome. Now, the basic science, this next bit's quite hard going, and I'd recommend this paper. It's from the Instructional Course Lectures 2013, but there's a lot on the website. This one's particularly written for orthopedic surgeons. So the basic science looks complicated, but it's all to do with this cell here, the macrophage. So these are particles activating the macrophage, which then becomes an activated macrophage, and using paracrine substances such as interleukin 1 and 6, tumor necrosis factor alpha, chemokines, prostaglandins. It activates other macrophages, getting them ready to do phagocytosis to fight this bacterial load, which isn't bacteria, and it also works on itself. You get systemic recruitment of other macrophages from the blood supply, which then differentiate. You've also got osteoclasts around, which are then activated by all of these interleukins, and there's a whole host of in vitro studies you can learn, but basically it's interleukin 1 and 6, tumor necrosis factor alpha, that does most of it. So tumor necrosis factor alpha also works on osteoblasts, which then stimulate the osteoclast via the rank L, mainly via rank L. But there's normally a feedback loop and a balance between osteoblasts and osteoclasts, and this pushes it in favor of the osteoblasts rather than the osteoclasts. They then activate and cause bone resorption. The particles also act on the cells themselves, activating the osteoblasts, the osteoclasts, and mesenchyme and stem cells to cause more bone resorption. So basically the usual bone turnover is put much more in favor of bone resorption. That's for normal particles, but metal particles also have this type 4 immune reaction via the T lymphocyte. So looking at each cell in part, there's a few complicated slides, so bear with me. So the macrophage, or the monocyte, is a dominant cell type in osteolysis. It's vastly present in the periprosthetic tissue and the pseudosynovial membrane, and it's correlated with bone resorption. And it secretes these matrix metalloproteinases, or MMPs, and they're enzymes that can dissolve the stroma and the fibrous tissue around the hip. It also secretes tumor necrosis factor alpha, interleukins 1 and 6, and eicosanoids to phagocytose the wear debris. Systemic migration of these macrophages also contributes to local infiltration, osteoclast differentiation, and bone destruction. Dendritic cells present bacteria and to the immune system, but they infiltrate and surround the plastic particles, participating in phagocytosis and MGC formation. They can produce pro-inflammatory cytokines, again the interleukins 1 and 6, interleukin 12, tumor necrosis factor alpha, and interferon gamma. And these are in the prosthetic synovial pseudomembrane. Osteoblasts can also phagocytose wear particles and alter cellular signaling. They increase osteoclastic activity through the rank L pathway and macrophage colony stimulating factor. And that's if you in vitro put tumor necrosis factor alpha and interleukin 1 beta. They also decrease the osteoprotegerin secretion, which is part of the feedback loop, which usually inhibits osteoclasts. And this is all dose dependent. And then so basically, and the last 2 points, just they're decreasing the production of bone and collagen. Fibroblasts are present in the pseudosynovial periprosthetic membrane. They can express rank L and can also induce osteoclast differentiation. And they're activated by tumor necrosis factor alpha and interleukin 1 again. So you can see it's all this tumor necrosis factor alpha, interleukins 1 and 6 are the main factors. And the fibroblasts are again producing the matrix metalloproteinases that just start dissolving all of your tissue. Sorry, one way. So take a deep breath now. Particle size. The hip wear usually produces 0.1 to 1 micrometer size particles. When I was going through my exam, I got confused between micrometers and nanometers, but we're going to deal with micrometers. The knee average is 280 micrometers in length. You can see the hip produces much smaller particles, and these smaller particles are much more active. The plastic in the 0.1 to 1 micrometer length are thought to be the most biologically active. And how the body deals with it, if it's 0.15 micrometers, they're pinocytosed. Pinocytosis is when it just drinks when the cell drinks the small fragments. 0.15 micrometers to 10 micrometers are phagocytosed. And these are the little things we're most concerned with. Greater than 20 micrometers induce multinucleated giant cell formation. So you can see why you can have a lot more wear actually in the knee, because they're bigger particles, they're less biologically active, and you get less bone loss on generally. We've all seen horrendous knees where they've got massive osteolysis, but usually you've got much more plastic volume, but because they're bigger length molecules, you get less biological action. We saw in that slide that medical particles show type 4 reaction. And initially, when we had highly cross-linked polyethylene, it produces smaller, more active particles. And this is one of the reasons why cross-linked polyethylene wasn't ubiquitously uptaken when it first came out, because it produced a lot more lysis in vitro. Ceramic particles have a variable reaction. Most of them come from the edge of the head or socket from abnormal wear. Most particles are less inflammatory, and zirconium oxide particles may actually suppress the inflammatory response. Looking at the host, every cell and tissue has a different threshold for damage, and this can vary between people and even at joints. Some genes have been identified that identify people as being more susceptible to osteolysis. And osteolysis also induces an inflammatory response in humans, which is pro-cardiac and pro-renal disease. So now we're getting out of your panic zone and back towards your comfort zone now. We're losing a lot of that basic science stuff, which is scary to most of us hip surgeons. So we're going to go back to orthopedic bread and butter, osteolysis, Charnley, Gruen, and some failure modes. So Charnley and DeLee, they looked at socket loosening. And basically, they made a right angle going through the head of the socket with a, sorry, just getting rid of the cat. A horizontal line going between the two heads of the balls, 90 degrees, and made 3 zones, 1, 2, 3. 1 is lateral, 2 is supramedial, and 3 is inframedial. And Charnley noticed that you often get a radiolucent line here, just supralaterally in zone 1, and it wasn't thought to be relevant. It's not a sign of loosening. But if you get a radiolucent line in zone 3, that's a gap between the bone and the implant, that's usually very significant. So sometimes loosening can be fairly obvious to the trained eye or not. You notice, first of all, that if you look at the teardrop here, the teardrop's there, the cup should be below the teardrop, and it's gone north, and there's a big defect in Kohler's line. But you can see there's loosening between the bone and the component all the way around, and this cup's obviously loose. On the left here, we've got a cementless implant. I put this in to show the large lytic lesion in here, which is due to osteolysis. You can see there's been volumetric wear. It's against the joint reaction force perpendicular, so it's volumetric wear rather than linear wear, and it's caused plastic particles that have gone up there. Sometimes osteolysis can be dramatic, and you can get a fracture with the osteolysis, and these are fun to fix. Gruen and Amstutz in 1979 they looked at 302 failed cemented stems, and they come up with some quite useful things that we still use today. One of them is the Gruen zones. And what he did is basically took from the top of the implant where it goes in the bone, not the very top of the implant, but where it goes into bone and the bottom, divided that into 3 zones, just in thirds, and went from the lateral side round to the medial side, giving us 7 zones, 3 on the lateral, 3 on the medial, and 1 underneath. And it's very useful to describe where the hole is, and it also helps you give you some knowledge about what you can do, what you have to do if you're coming to revise that hip. So transferring that clinically, if we have a cemented stem here, and you want to describe where the radiolucent lines were, and to also think about what was happening biomechanically to that hip, and what was like to happen, you can just draw your lines on. So I've line at the bottom, line at the top, and divide that into 3, just the same as Gruen did. And then you can describe, well, in zone 1, I've got a radiolucent line here, and also in zone 5, I've got abnormal bone there, and I can just see a gap between the implant and there's a line there. So is that relevant or not? Don't know, but at least I can describe zone 1 and zone 5, that there's changes. So this is normally where I stop and ask the audience. So the audience, what do you think about this? What's going on? Leave you for a minute just to think about things. So you can see we got zone 1, 2, 3, 4, 5, 6, and 7. And can you see there's a gap here? We often see wear particles going down here because you've got gravity, you've got the synovial capsule here, and the wear particles accumulate with gravity and they can come down inside here. And that's caused a large radiolucent line. You could even say there's endosteal scalloping. There's also a radiolucent line here, which is small, but it gets bigger as we come into zone 1. And then looking at the cup, you can see there's lucency all around here and around here. And again, the cup's gone north. It's loose. I put this image in because this is a cementless hip, showing exactly the same problems, the same thing that Gruen described with cemented hips. You can use Gruen zones in cementless hips. It's absolutely fine. And you can see again a large radiolucent line between the trochanter and the stem in zone 1, 2, 3, a little bit of a radiolucent line, 4, 5, 6, and 7's the best of them all. Gruen then described the modes of failure, and these are described into 4 different patterns. The first one is pistoning within the cement. So you've got the tube of the femur, and the stem goes up and down in it. Now that can either be the stem within the cement, or the stem and the cement within the bone. Type 2 is the medial mid-stem pivot, where you've got a bit of calcar resorption, there's nothing supporting it up there, and what happens is the stem then tips into varus. Calcar pivot is where there's intact support right at the top on the medial side. What happens is the tip of the stem windscreen wipers within the cement. And the last one is where the distal bit is fine, but all of the cement has got loose around the top of it, and there's no support for the middle and top of the stem. And what happens is that then fractures usually because there's no support for the stem. So an example, on the right hip, we've got a cemented hip. What mode of failure do you think has happened? Well, you can see here, that's the shoulder of the prosthesis, and there's the shoulder of the cement. So that's obviously dropped a significant amount. So it could have been put in like that. So they could have let it off, let the cement go, and then just as it was going off, pushed it further down. But I suspect that has sunk over time. If you look around here, there's a radiolucent line between the cement and the bone, and a bit of osteolysis there, a bit of endosteal scalloping, and it's all loose all the way around, radiolucent line all the way around. So I suspect that mostly you've got the stem and the cement within the bone, 1B, but there's a little bit of 1A, so there might be a cement fracture as well. This one, just giving you a second to think what's happening here, what mode of failure is happening in this case. So you can see we've got some calcar resorption. There's no support there, but there is support still here. And what's happening is you can see there's a radiolucent line there, and the stem is tilting into varus. And we've got this periosteal reaction. What's happening here is they've got some cortical thickening where the bone's being loaded because the force of the tip of the stem is going laterally and it's reacting with the stem as it's getting looser. So this is type 2, medial mid-stem pivot. Also looking at the cup, just for practice, you can see it's loose all the way around. We've got the medial side is loose, which is the bad sign. Loose, so that's needs both sides doing. This one, you can see a lot of wear, volumetric wear again. It's gone perpendicular to the joint reaction force, as well as a bit of linear wear. And we've got a radiolucent zone in zone 1, and we've got a bit of lysis down here. But you can also see a radiolucent zone in zone 7. So what's happening here again is it's doing a medial mid-stem pivot. This one on the left, have a think. Where's the radiolucent lines? So you can see it's coming down here to about there. So that's zones 1 and 2. But zone 3 hasn't, and you can see you've got some thickening of the cortex down here. Zone 4 looks okay, zone 5 looks okay, but again, zone 6 has a radiolucent line, and zone 7. So we've got a distally fixed stem, and the bone's reacting again. We've got cortical thickening where the bone's got thicker, and up here stress shielding, because there's no weight going through this bit. So which mode of failure is that? That's the cantilever one, the end one. And these are more difficult. I find these more difficult to revise because the cement's always really well fixed down here. And trying to get that out without breaking the femur can be tricky. And for those of you who haven't seen, this is a Mexican hat, which is the old way of doing the Chana. You had to drill through the femur first, the socket first, to identify how deep to put your reamers. Then you put this in and cement it in it. And the old keyhole. So we've talked about radiolucent lines, but when is a radiolucent line significant? Well, Gruen said that if it's wider than 2 millimeters, it's significant, it's evidence of loosening. If it's less than 1 millimeters, it's acceptable. And if it's not progressive, it's acceptable. Progressive means on serial x-rays, if it's getting thicker or longer, then it's a sign of loosening. But again, he's very astute, Gruen, and this is very important, clinically asymptomatic. So if you've got somebody who's asymptomatic, it's less likely to be loose than somebody who's symptomatic, even if they've got normal looking x-rays. Always compare with a baseline study. And if you've got radiolucent lines straight on the offset, sometimes you've done a hemiarthroplasty and you can see a radiolucent line. And it's not loose, it's because of either poor cement packing, interposition of blood or fibrous tissue, or even a swab sometimes. Or you've moved the prosthesis before the cement's gone off. So you've got a little defect in the cement that you can see as a radiolucent line. Now in cementless hips, no, don't believe the companies, they do get loose. Again, so between 1 to 2 millimeters of loosened zones can be normal. This is normal. You can normally have the calcar resorbed. Again, what happens is if you've got a collar especially, the wear particles accumulate in the joint, and then gravity means that they're most active below the calcar. And you can have cortical thickening or periosteal subreaction. Sometimes that's abnormal. Sometimes it's normal. And I like how he described non-progressive mild subsidence of less than a centimetre of femoral component, i.e. if it hasn't moved a centimetre, it's not loose. I'm not sure about that. Sometimes a millimetre or two is all you need to make it loose. And the other problem is that sometimes with these cementless hips is that you put them in, but you've undersized them, and they then sink down the femur, and then they get secondary stability, secondary fixation later, but further down the leg. So in your first post-op x-ray, they might be where you wanted them to be. And then at your year x-ray, they're 2 centimetres down the femur, but they might not be loose because if it doesn't go any further, it's stuck. So the next paragraph is indicative of loosening, so it's normal, indicative, and diagnostic of loosening. So indicative, so loosening's probable. Progressively widened lucent zones at interfaces greater than 2 millimeters. Bead shedding, so that's when it shows that things are moving. So you're shedding the beads and the coating of your prosthesis. And endosteal scalloping, such as this, where the inside of the cortex, you're getting a cutout like a tumour of the cortex being resorbed. Diagnostic for loosening, migration or change of position of component, especially if it's progressive, and progressive subsidence of either the acetabular or the femoral component. And again, Gruen's modes of failure applies to here, apart from we don't have cement. So again, you can have pistoning, medial mid-stem pivot, cow-car pivot, but the common ones, the cantilever bending. So what's happening here? What sort of stem is this? Can you see cement? No. Has it subsided? Well, this is one of the proximal third coated prostheses, and this is the proximal bit, and that should have been at the neck cut. So that bit there was probably up here when it was put in, and that bit was probably up there. So you can see, what can you see here? Radiolucent lines in zone 7, and sorry, zone 1 and 2. Sorry, zones over here. Zones 1 or 2. And you can also see these radiolucent lines further down. So this looks loose to me because it's going further down, and it's subsided, and you've still got these radiolucent lines. So that is pistoning. So in summary, all artificial joints produce wear particles. And you have to learn the osteolysis cascade, both for the exam and also how to explain it to patients. Even if you want to be a hand surgeon, you see this. But when's a radiolucent loon a lytic line, and what's their relevance? Hopefully I've tried to go through some of that, but it's not a black and white thing. You've got to listen to the patient and remind that if a femoral stem's loose, they usually get thigh pain. And if an acetabulum's loose, they usually get groin pain, very similar to their arthritis. So they get groin pain when they're twisting the socket, getting up and down from a chair. We've also talked a little bit about bone remodeling and stress shielding. So I hope you stuck through this with the basic science. Thank you for your attention, and any questions I'd be happy to answer. Usually I say this is a question and answer one, but come and find me, or comments in the below, as they say, and good luck.